Thank you very much. Today is September 18th, 2024, and we are starting the WBMT webinar on the use of post-transplant cyclophosphamide to prevent graft versus host disease outside the haploidentical setting. I'm Adriana Seber, and I'm talking to you as a member of the Education and Dissemination Committee of the WBMT, that I have the pleasure of sharing with Dr. Damiano Rondelli, who's the president now of the WBMT, and Dr. Dietger Niederwieser from Germany. This webinar will have three very important speakers. The first is Dr. Javier Bolanos-Meade from Johns Hopkins University. He will talk to us on the GVL effect of post-transplant site in the matched and one antigen mismatched transplants, if there is a role for post-transplant cytoxin dose reduction. And then Dr. Clarice Machado from Hospital Amaral Carvalho in Jaú, Brazil, and Institute of Tropical Medicine of the University of São Paulo. And she'll talk to us on the pros and cons of using PTCy on viral reactivations. How should we follow the patients, do prophylaxis and treatment? And the last one will be from Dr. Biju George from Vellore Indian Christian Medical College, who talked to us why to use PTCy in matched transplants to treat the non-malignant diseases. And all three speakers have a huge experience of using PTCy. And follow the talks, we'll have a panel discussion moderated by Dr. Damiano Rondelli and Sebastian Galliano. And we thank you very much for being with us. Please, during the talks, you can type your questions on the Q&A link that you have below, and we'll be answering them at the end of the talks. All the questions and discussions will be at the end, and we'll have about 15 minutes for the discussion. So our first speaker, Javier Bolanos-Meade, thank you so much on the GVL effect of PTCy in the matched and one antigen mismatched transplants. Thank you very much, Javier.
Thank you for the invitation. And let me just share. I hope that you can see the slides. As I said, thank you, Adriana and Damiano, for the invitation. I'm Javier Bolanos-Meade. I'm coming from Johns Hopkins in Baltimore on the East Coast of the United States. And yes, I've been working with cyclophosphamide for over 20 so years in any potential setting that you can imagine. So hopefully we'll be able to make a case and answer your questions. Now, let me, so my disclosures, everything we're going to talk is off level. I really don't have any funding to disclose. This is, I'm not trying to single out a paper, but this is one of the many papers that are out there suggesting that perhaps cyclophosphamide is a cause for decreasing the graft versus leukemia effect, and therefore one needs to be careful. Now, historically, we need to remember that any agent used to decrease graft versus host disease to prophylax against this complication will historically translate into higher number of infections as well as a higher probability of relapse. So suggesting that cyclophosphamide can do the same is not entirely crazy. Now, however, do we know if this is true? Do we have the data to suggest that this is true? And I will try to go over the data that we have to try to prove one point or the other. Now, this is an important slide because this was our original theory about the way in which cyclophosphamide worked when we started doing this at the end of last century. And I want to believe that this is an outdated slide because we have proved that this is either not the main or even a mechanism, but perhaps it's a minor mechanism. But if this were to be true, when you give cyclophosphamide after transplant, you will essentially kill lots of alloreactive T cells, which will at the end translate into a state of immune deficiency that will not allow the establishment of graft versus host disease, but as a consequence will certainly create an environment in which relapse and severe infections will be possible. Now, we're not going to go over the reasons why I think that this is an outdated slide, but that's what we were thinking in 2003, 2005, and so on. However, back when we start publishing data in haploidentical transplants, which is not the main topic of today's talk, what we saw is that there were some diseases that were incredibly sensitive to a graft versus tumor effect. And this was one of the first papers that was published, in which if you see, there was a comparison between different types of transplants, and the only one using cyclophosphamide back then was the haploidentical, showing that graft versus host disease was not an issue. But the interesting thing about this paper was that the risk of relapse was decreased compared to the other options. And this was statistically significant. Now, you need to take this with a grain of salt. This is retrospective view, and it was not necessarily the best paper ever published in medicine. But this is a study, the first study that suggested that patients receiving cyclophosphamide had better disease-free survival compared to patients getting other type of prophylaxis. And then if the slide moves, yes. Now, there have been, I don't know how many studies published by the CIBMTR, because this was a topic that was of high interest a decade ago, in which we were comparing, well, cyclophosphamide versus non-cyclophosphamide prophylaxis and what happened. And again, these are a little bit different comparisons because they were comparing haploidenticals versus match. But what we were seeing is that, and there are plenty of papers, this is just an example. In the majority of papers, the only difference that we were seeing between these groups were that patients getting Cytoxan were getting less chronic graft versus host disease, but disease-free survival, overall survival, everything else was the same. And again, there are like tons of these studies. So the data that we were having at this point in time suggested that cyclophosphamide was perhaps not that evil, but the majority of these comparisons were checking on haploidentical transplantations, and we were going to talk today about non-haplo setting, and thankfully we have 3 mature, 2.5 mature studies that we can actually look back to try to answer these questions. And these are randomized studies, which were supposed to be the best kind of evidence. 3.5 studies. The very first one that we're gonna review was BMT-CTN 1301. And BMT-CTN 1301 was a study that essentially looked into myeloablation. And essentially, patients were randomized to 3 different arms, CD34 selection, cyclophosphamide, tacrolimus, and methotrexate. And these are the long-term outcomes and at 5 years. And what you can see is that at 5 years, the probability of relapse was the lowest if you were to receive cyclophosphamide. Also, the survival was the best if you were to receive cyclophosphamide. So in this particular setting, at 5 years, which is, I guess, a very decent follow-up, receiving cyclophosphamide as a single agent prophylaxis, this is without combination with MMF or a calcineurin inhibitor, in a randomized clinical trial, we have the best survival and the lowest relapse at 5 years using cyclophosphamide. So this study suggests that very likely there's no major problem with cyclophosphamide in terms of decreasing the graft versus tumor effect. This is the second study that we're going to talk about, BMT-CTN 1203. And this was a study in which, this is a randomized phase 2 study in which we were comparing cyclophosphamide against TAC methotrexate, and other agents were also compared against TAC methotrexate. As you can see, this is essentially what we're trying to do. This is not a comparison between the experimental arms, so each arm was compared against TAC methotrexate. And this was a large study. We were talking about almost 500 patients. Now, when it came to the primary endpoint, which is GVHD, relapse-free, and overall survival-free, cyclophosphamide was the only combination that was better than control, the TAC methotrexate. And as you can see, it was not a small difference. But when it comes to specifically the graft versus tumor effect, and which essentially translates into relapse and progression, in this study there was really no difference. Now this is at 12 months, but all the agents score, or all the arms score similar to TAC methotrexate when it comes to relapse and progression. And this translates into very similar disease-free survival and overall survival. So as you see in that study also, in reduced intensity conditioning using post-transplant cyclophosphamide, it doesn't appear that the use of cyclophosphamide was inferior in terms of graft versus leukemia, which is essentially seen as the probability of relapse. Now, you may remember that I said that we had so many and half studies. This is a half study, not because it was half a study. This is a very complicated study that was presented in ASH and subsequently published, the Obon 96, which suffered multiple modifications during the trial. And therefore, I'm not so sure that is the one that is going to answer our answer. And I'm actually going to not going to go into a lot of detail. However, in this study, the endpoint that is of relevance is GVHD relapse-free survival, which also was better with cyclophosphamide. Now, of all the, just like 1301 was a phase 3, we're going to go now over BMT-CTN 1703, which is a phase 3 study, but this time using reduced intensity. 1301 was using full myeloablation. And again, was a large study comparing cyclophosphamide versus TAC methotrexate over 400 patients. And sorry, as you can see in the in what it be the results of the study, the one that is important for the graft versus leukemia effect is panel D, as in David, in which you can see that disease-free survival was well, because this was a secondary analysis, we cannot say that it was better even when the P was better, but this is considered exploratory result. But disease-free survival was better using post-transplant cyclophosphamide. Now, you can see that the other outcomes were also better. The adjusted GVHD relapse-free survival was better for cyclophosphamide. Acute GVHD grades 3 and 4 were better with cyclophosphamide. Chronic GVHD was also better with cyclophosphamide. And overall survival, at least at this point in time, was not inferior for cyclophosphamide. So what you can see is specifically talking about the graft versus tumor effect. Yeah, it appears that cyclophosphamide in all these randomized studies was not affected by the use of the drug. Now, just because this is a very short period of time that we have to go over these results, one of the questions that Adriana had for me was whether decreasing the dose of cyclophosphamide was useful. There are few studies that have been published using lower doses of cyclophosphamide, but all these are exploratory studies in which they're more of a feasibility type of trial that is, yes, we can do it, and patients apparently don't fall apart. But we don't really have any solid evidence to believe that decreasing the dose of cyclophosphamide will actually translate into the same result. Is it possible? I'm sure it is a possibility, and that will have to be proven with the right clinical trials. But as of right now, all the evidence that we have with dose reductions of cyclophosphamide is feasibility. We know it can be done. Is it better? Is it worse? We have no idea. Now, going back to 1703, as you can see, disease-free, not particularly different. The incidence of relapse at 1 year, not particularly different. So cyclophosphamide in the setting of HLA match or one antigen mismatch does not appear to be associated with a decrease on the graft versus leukemia effect when compared with methotrexate and a calcineurin inhibitor. And essentially all the outcomes that we saw or that we analyzed in 1703 show either an advantage of cyclophosphamide or no difference except for two, one of which I think is going to be discussed a little bit earlier, which is incidence of infections. That appears to be a small increase in the possibility of infections, but not severe infections. And there's a little bit of a delay of engraftment. I will be happy to go over your questions a little bit later, but thank you very much for your attention.
Thank you very much, Javier. It's a pleasure to have you, and we'll be waiting for the discussion time. We have in the panel, among the audience, we have people with hands raised. So I would ask if it would be possible, please, to write down your questions in the Q&A, and we'll have the discussion in the end. And now we have the pleasure of having with us Dr. Clarice Machado. She's from Brazil, from Hospital Amaral Carvalho in Jaú, Institute of Tropical Medicine, University of São Paulo. Dr. Machado will be talking to us about pros and cons of PTCy on viral reactivations. How should we surveillance, prophylax, and treat the patients? Dr. Machado has a huge experience helping us in Brazil dealing with these transplants. We are very, very thankful for having you with us. Thank you very much, Dr. Machado.
Well, thank you for the invitation to participate. I'm happy to be here. And these are my disclosure. And we'll talk about a little bit on immune reconstitution, the pros and cons of PTCy, and the surveillance strategies and the management of viral reactivations. Oh, in allo HCT, what do we want? We are getting closer, but still not there. We want an increased number of possible donors. We want decreased transplant toxicity, a strong engraftment, decreased GVHD while keeping GVL, decrease relapse, increase overall survival, and better control of infections, and much more. We want a lot. And the control of infections is driven by immunosuppression, so it's driven by immunosuppression, so we have to take a look on that. In the last decades, we have seen the increase of haploidentical transplants and also PTCy for GVH prophylaxis beyond the scenario of PTCy haploidentical. Summarizing 3 studies that analyze the immune reconstitution after PTCy, what we see that we have a delayed recovery of T cells, faster B cells recoveries in haplo, and also in unrelated HCT. We also, studies show that a transient early delay in CD4 and CD8 T cells recovery in haplo, but rapid CD4 and CD8 effector memory cells, and delayed NK, T, and B cells recover up to day 50 in unrelated HCT. But we have to take into account that immune reconstitution is a dynamic process, and everything is seen in a study may change if GVHD appears and the scenario of immune reconstitution can be altered in few days. I picked this picture from one of these. This is a Brazilian study that will be published soon, that are in unrelated donors, matched unrelated donors, just to show you that in the PTCy transplants, we have this sharp decrease of lymphocyte subsets around day 30. So, and if you look at the occurrence of viral infections after transplantation, you can see that coincides with this exactly this period where we have the reactivation of HHV6, we have the hemorrhagic cystitis with BKV, CMV, and also EBV occurring very close to this period. And they are occurring even earlier with the PTCy. So starting with the cons of PTCy on viral reactivation, we have during this period, the early post-transplant period, an increased susceptibility to viral reactivations. We have then to expand the virus monitoring and be aware of the limitations of the surveillance techniques. And in this period also, we have to use toxic antiviral drugs just in the peri-engraftment period, what is not good, and we don't have many alternatives. And this is one of the first studies in 2016 that showed the differences of CMV, EBV, and HHV6 reactivation in the scenario of haplo transplants in comparison with matched unrelated donor. In the study, they didn't see a difference on CMV reactivation, but we can see a sharp difference and decrease in EBV reactivations in the haplo transplants, and an increase on HV6 in the haplo transplant. When we compare CMV with unrelated, the fact is that unrelated transplants had already increased the reactivation of CMV. So they didn't see difference, but when you compare with the matched related donor, there is a huge difference on CMV reactivation. So this is another study that confirmed that comparing PTCy and TG in reduced intensity conditioning, and they observed also similar rates of CMV and BKV, but high number of HHV6 reactivation in PTCy in comparison to ATG, 53% and 7%. And when you look in the haplo, it's much more than in the MUD, 70% and 20%. Also, they show again that EBV reactivation was much more related with ATG, the use of ATG, than with the PTCy. So we can see that 73% using ATG had a EBV reactivation. Oh, this is the CIBMTR study showing what I have just said, that the increased number of CMV reactivations with the use of Cy, even the matched related transplant. If you use Cy post-transplant, PTCy, you have the same high incidence of CMV reactivations in comparison with the classical or the conventional immunosuppression. This is another study showing lower EBV reactivation rates in PTCy versus ATG. This first study, a recent study showing a small frequency of EBV reactivation, and this recent meta-analysis showing that I have the risk of EBV-related PTLD much more in the ATG group, 29 episodes, and than in the PTCy group that had just 4 episodes. So proving that ATG is the major risk for EBV reactivation and PTCy. This is the same meta-analysis showing that this is not the same for CMV or BKV, that although a slightly different higher number in ATG group, though it didn't reach statistical significance. This other study, also a recent study showing that EBV reactivation is a marker of HHV6 reactivation, sorry, is a marker for the occurrence of graft versus host disease grade 2 to 4. And you can see that a patient who had early HHV6 reactivation had a 39% risk of acute GVHD in comparison with 9% of those who didn't reactivate HHV6. So this is, we had the same experience in our center. We have studied that before. And also in this study, the authors could find a cutoff for the absolute lymphocyte count as a biomarker for the occurrence of HHV6 reactivation. And there are other studies from Japan that show other lymphocyte subsets like a CD134 showing that a higher risk for reactivation depending on the proportion of the subsets. Here, this is our experience in our center, Hospital Amaral Carvalho. We analyzed almost 400 patients from 2019 to 2022. And we have, for instance, comparison of several types of transplant with CMV reactivation. We have almost the same high cumulative incidence of CMV reactivation. You can see that the slower proportion is still high in the matched-related donor, but when we use in matched-related, we use a TG in this group of patients. The frequency of CMV reactivation is high, like in the other high-risk transplants. For the EBV, we can see that the highest incidence is for the MUD, and second for the matched-related donor with ATG, and then haplo and the sibling with the conventional immunosuppression is the lowest incidence. And for HHV6, the top incidence occurs in the haplo with PTCy, and the second in the MUD. So this is our experience. And what are the cons? Other cons: the need of expanded monitoring in the limitations of the techniques. So what we have to do with these infections? For CMV, we can monitor with PCR or antigenemia. The recommendation is to do it weekly in the first 100 days and extend it to at least 6 months. In the case of GVH, of letermovir prophylaxis or active GVHD, you have to prolong the monitoring. The other virus, the recommendation is weekly in the first days. We have maybe this will change for EBV, for instance. Maybe it's not the need to do it every week for in the PTCy group, but in general, for the matched-related donor, we just the recommendation is obviously CMV. In the ATG, we have to monitor CMV and EBV, and ADV, adenovirus. The better evidences of benefit this monitoring is for children. In adults, not that clear. And for the PTCy, the guidelines still do not recommend AGHV6 monitoring, but it goes at a transplant discretion. So some centers are doing. In my center, we used to do it because we can early detect signs of CNS alterations, and we can start treating an early diagnosis of encephalitis and treating earlier the patient. Also EBV and ADV. And which are the limitations of the PCR? International units per ml, and perfectly released the results within 48 hours. The cutoff has to be defined locally. This technique is impossible. With this technique, impossible to discriminate blips and true reactivation during letermovir prophylaxis. So the center and the physicians had to be used to use the technique and letermovir to feel which is the situation. For EBV PCR, we don't have any cutoff defined to introduce preemptive rituximab, which is probably overused. And the other complications that the severity of the reactivation or disease not always related to higher viral load, differently from CMV. And for the ADV PCR, the cumulative incidence is very low. In children, a little bit higher, but still low. And we have to evaluate the cost of this. And the predictive value for disease also is low. So we have to consider the cost benefit of monitoring. And we don't have an effective and safe antiviral to use. Another cons is the need of toxic antiviral drugs in the peri-engraftment period. And there is a study, I'll show some studies from Brazil. There's a study from Rio de Janeiro, Professor Marcia Garnica, and the occurrence of CMV DNA EMEA before engraftment in allo HCT in this center was high, 42%. And you can see that in patients who had the median time of occurrence of early CMV pre-engraftment was 16 days in comparison to 20 days in patients without CMV early CMV reactivation. So the CMV reactivation retards the engraftment. And also they could show the impact of this in the survival of the patient at day 101 year after transplantation, and patient who had pre-engraftment CMV, the anemia, had a lower survival. And this is our data. We had published. I intend to show this data in the next Sunday. We only in PTCy, we evaluated the primary graft failure, and we had a higher incidence of graft failure when patient reactivates CMV earlier. And we defined this as the reactivation occurring before engraftment or up to 2 days after engraftment. And this causes also a higher incidence of bacterial infections and interferes and decrease overall survival. This is another study showing the importance of AGHVC. This is the univariate analysis and the multivariate analysis for the risk factors associated of primary graft failure. And you can see that AGHV6 viremia increase almost 3 times the risk of primary graft failure. So this is a virus that we cannot just ignore. Of course, the pros of PTCy on viral reactivation, we can observe later during the transplant period, by the reduction in acute and chronic graft versus host disease. This decreased the risk of viral reactivation that is associated with the treatment of GVHD. And also the CD4 and CD8 rapid recovery of effector memory cells decrease the risk of EBV reactivation and also PTLD that we are observing this in the prats with the decreased number of EBV reactivations. So the management of viral infections for CMV, first option is letermovir prophylaxis to abolish the survival disadvantage of seropositive recipients and to avoid the indirect effects of CMV. Also, if preemptive against cyclovir, if prophylaxis is not available or if prophylaxis fails. And in the case of refractory or resistant CMV, we have maribavir as first option, but with around 60% success rate, not too much. And also, still perspective is use the specific T-cell monitoring, also specific T-cell therapy, and also CMV vaccines are emerging. For BKV and ADV, we currently do not have any good options to treat them, but I can see that in short term, the specific T-cell therapy is a good option, but we still have some things to do. And for the EBV, as I mentioned, we have maybe we need to do it less frequently and carefully evaluate the need of rituximab. In the case of HV6, monitoring is not always recommended, but we have to exclude chromosomic integration. So when I stop here, and I'll be glad to answer questions. Thank you.
Thank you very much, Clarice. It was wonderful. We'll have to keep the questions at the end. People are already typing in the questions, so they will be all answered in the end. And now we have the pleasure of having Dr. Biju George from Christian Medical College in Vellore, India. Will talk to us about why to use PTCy in the matched transplants to treat non-malignant diseases. He has lots of experience. It'll be wonderful to hear him. Thank you very much, Dr. George.
Thank you very much. And I'd like to start by thanking WBMT for giving us this opportunity to talk about the use of PTCy in matched sibling donor transplants in the non-malignant setting. I would start by saying that data on the use of PTCy in non-malignant diseases in a matched sibling donor setting is actually limited. There's much more data available in a haploidentical setting. But what I would like to talk about is a little bit in terms of data which is available for aplastic anemia and thalassemia. Now, when you come to a developing country, one of the biggest challenges that we face is the fact that patients are referred late for a transplant, whether it's thalassemia or aplastic anemia. They end up having multiple transfusions. Transplants are late because of financial constraints. That leads to more rejections, more infections, lower survival. And one of the strategies that transplanters have used is to use peripheral blood stem cells rather than bone marrow as grafts in patients who are having transplant for non-malignant disease, but who have high-risk features. Now, in the West, of course, it is not a good practice to use peripheral blood stem cells in non-malignant disease, but this CIBMTR study, which was done a few years back, actually showed that in lower income countries, there was a benefit of using peripheral blood stem cells over bone marrow in aplastic anemia, which was very different from the high-income countries. Importantly, it was associated with faster engraftment, which is good when we look at the fact that a lot of patients come into transplant with infections. However, the price we pay for it is the fact that we have higher incidence of acute and chronic graft versus host disease. So how do we reduce acute and chronic graft versus host disease? Of course, the first thing would be to change to bone marrow as a graft instead of peripheral blood. But with the higher rejections and infections, you would prefer to use PBSC. If we decide to use PBSC, what can we do? One option is to add ATG to the conditioning regimen. In developing countries, that is a big challenge because ATG would add another 20 to 30% to the cost of a transplant. And so that is where we sort of explored the idea of using post-transplant cyclophosphamide in patients having a matched sibling donor transplant for aplastic anemia, taking data from the haploidentical transplant where they showed that the use of PTCy was actually useful in reducing graft versus host disease. So initially, when we did our transplants, and this was data published about 15 years back, we had changed our protocol because we were not doing very well with cyclophosphamide ATG, which is the standard of care. We had shifted over to a fludarabine cyclophosphamide made conditioning. So we had about 35 patients with all had PBSC, all had cyclosporin methotrexate as graft versus host disease. They all engrafted, low rates of VOD, but had about 30 to 40% incidence of acute and chronic graft versus host disease, although the survival was very good. So based upon data which was available from the haploidentical setting, we actually set up a phase 2 study looking to see whether it was feasible to use post-transplant cyclophosphamide in patients having matched sibling donor transplants for aplastic anemia, where we were using PBSC as the graft source. And this was the kind of schema we had using fludarabine. We used cyclophosphamide. We reduced it, our original dose, from 120 per kg to 100 because we were going to use 100 post. We added on a single dose of TBI, and we gave between 6 to 8 million peripheral blood stem cells. We studied about 30 patients in this group. So this was mainly adults, median age is 29, median transfusions were about 20, 1 had failed ATG, 9 had previously used cyclosporin, some of them had infected. The important thing was that more than 95% of Indian patients are CMV seropositive prior to transplant. The MNC was about 4.7 and a median of 8.9. Most of them engrafted, so graft failures were only in the region of 3%, prompt engraftment, and importantly, acute and chronic GVHD rates were very low, but we had a higher incidence of viral infections both CMV and non-CMV infections. So what we did was to take this data and compare it with our earlier cohort of patients. There were two cohorts, one which got methotrexate 15, 10, 10, 10 with cyclosporin, and a second group which had got 10, 7, 7, 7. The baseline characteristics for both the groups in terms of the amount of CD34 used, everything was similar. But what we saw was that we managed to reduce acute GVHD rates from 50 and 37% to 22%. We managed to reduce chronic GVHD rates to again 22% as compared to 60 and 70%. All of them we used PBSC. The overall survival was not different, but event-free survival in terms of chronic GVHD-free, rejection-free survival was actually very good with the post-transplant cyclophosphamide. Now, the other added advantage was that if you look at our schema, we did not actually use anything beyond the 2 doses of PTCy, and roughly about 46% of patients did not require any further immunosuppression. So it was actually a cost saving for us for this 46% for a year of cyclosporin. 6 patients developed acute GVHD requiring the use of cyclosporin and methylpred. 4 are alive and well, while 2 with grade 4 GVHD had expired. The important thing was we saw much higher incidence of CMV and other viral diseases with these patients as compared to what we were seeing with cyclosporin methotrexate. So this is the kind of incidence of acute GVHD. This was with PTCy as compared to methotrexate 10 and methotrexate 15. And importantly, this was the incidence of chronic GVHD. So you notice that both with acute GVHD and chronic GVHD, we managed to get very low rates. And survival was not different because we lost a few patients due to sepsis and viral infections, but the event-free survival in terms of chronic GVHD-free, relapse-free, rejection-free survival was much better with post-transplant cyclophosphamide. Now, this is updated data which is not yet published, but so far we have used in about 65 patients, which has gone up from the 30 primary graft failure in about 7.6%. We still have very low rates of acute GVHD, 18 and 23%, and CMV reactivation is still a problem. Right now, we have a active randomized controlled trial that is going on where we are comparing PTCy versus cyclosporin methotrexate in the matched sibling donor transplant. We hope in the next 2 years we'll be able to complete this trial. There was another publication actually from Egypt where they looked at the use of PTCy again in matched sibling donor transplants, although they used a slightly different schema. So they had fludarabine cyclophosphamide conditioning, but they used PTCy, and on day 5 of PTCy, they started cyclosporin and gave it for about 12 months, and they compared it with the standard cyclosporin methotrexate as the other GVHD prophylaxis arm. There were about 30 patients studied in each arm. There was 10% graft failure in PTCy, while there was nil with cyclosporin methotrexate. But very importantly, the rates of acute and chronic graft versus host disease was much lower with the use of PTCy with cyclosporin as compared to using cyclosporin with methotrexate. They were in the region of about 10%, both acute and chronic, as compared to 36 and 56%. The overall survival was not different. And again, here, one of the major problems was infections and deaths related to infections. The last what I would like to talk about is, and this came actually as recent as September 2024, there is this publication from China looking at the use of post-transplant cyclophosphamide in both matched sibling donor and haploidentical donor patients who have thalassemia major. So what they did was a myeloablative transplant consisting of rabbit ATG, cyclophosphamide, fludarabine, and busulfan. They used peripheral graft in all of them. So they gave PTCy on day 3, 4, and they combined it with methotrexate and cyclosporin. GCSF was started on all patients. They had about 160 patients in this total paper, but out of this, only about 13 were matched sibling donor transplants. And what they essentially showed that the incidence of acute GVHD, and what I show here in the blue line is what it was in matched sibling donor transplants. It was in the region of about 10 to 12%, the incidence of acute GVHD, despite the use of peripheral blood stem cell transplant. The incidence of grade 3 to 4 acute GVHD was in the region of 5%. And when we looked at any acute and chronic, you see here, it is very low when it came to matched sibling donor transplants. And importantly, it did not affect the overall or the event-free survival. This was for the entire group. And then you looked at almost 98% survival in the matched sibling donor group. And you looked at about 95% survival when you looked at event-free survival. So this again goes to show that although it's a very small number, cyclophosphamide still may be a useful drug to use in non-malignant diseases to reduce the incidence of graft versus host disease, especially when you're using peripheral blood stem cells as the graft source. So I would conclude by saying there is limited data available on the use of PTCy in matched sibling donor transplants for non-malignant disease. However, whatever data is available, the use of PTCy in non-malignant disease is associated with very low incidence of acute and chronic graft versus host disease. CMV reactivation is a major problem even in matched sibling donor transplants, more so in populations where CMV seropositivity rates are very high. In India, we are sitting at more than 95%, and so it's a major challenge. But despite that, the good reduction in acute and chronic GVHD means that we need to explore further the use of PTCy and matched sibling donor transplants for non-malignant disease. With this, I'll stop and I'll be happy to take questions.
Thank you very much, Dr. George. I would like to invite everyone to open their cameras and have Dr. Damiano Rondelli, the WBMT president, and Sebastian Galliano from LABMT, our wonderful colleague, to run the Q&A session. And we already have many questions. Thank you so much.
Thank you. Thank you, everybody, for your presentation, for attending. We have about 10 minutes for the questions, so I'd like to ask you to be rapid in the responses, and we have tried to address all of them. I'd like to start with a first question is actually could be for Clarice or for anybody of you. Is there any data on the effect of post-transplant cyclophosphamide on JCV-associated PML post-transplantation with PTCy? I don't know if there's any data on progressive multifocal leukoencephalopathy.
Yeah, JC virus, yeah. Clarice.
I didn't understand the question.
Is there any data
on
correlating JCV, PML, progressive multifocal leukoencephalopathy in post-transplant with PTCy? Does PTCy increase the risk of JC virus PML?
We know that it increases BK virus, but we don't know if it could also increase the polyoma JC virus, if you ever heard of or studied.
No, I don't think we have evidence for that.
I'm sorry, I know of at least one case report published on that, But I can tell you that after thousands of people transplanted with cyclophosphamide in our center, we have never seen it.
Thank you. Another question has been from two people. In match-related transplant using post-transplant cyclophosphamide, is it reasonable or is it possible, and we heard something from Dr. George, to drop mycophenolate and rely only on calcineurin inhibitors? Is that safe for GVHD purposes?
Yes, so in our study, we just use PTCy alone. The study from Egypt used PTCy with cyclosporin, and I think both these are associated with low rates of acute and chronic GVHD. So I think it would be safe to drop mycophenolate, at least in the matched sibling donor setting.
Now, I also presented the data on 1301, which was a randomized study after myeloablation, in which patients received only cyclophosphamide. They didn't receive anything else for GVHD prophylaxis. And as you can see for the slides that I presented for the long-term 5-year follow-up, the results, in my mind, are very, very good, because they had they show very good control of GVH, but they had also the best overall survival and the best disease-free survival. So yes, it is doable. It's you need to read 1301 in detail to be sure that you know what you will be doing, but it is doable, I guess. Not necessarily something that I will do today, but it can be done with decent results.
Sebastian, you want to ask a question or?
No, yes, there is one question also for Clarice about HHV6. If you find a positive result after the transplant, what is your approach? How do you manage this?
We monitor weekly, and we only treat if we have a delay in platelet or neutrophil engraftment, or if the patient starts showing some signs or symptoms of CNS alterations, like alteration of the humor, irritability, or something that suggests we take the CSF, and if it's positive, we start treating encephalitis.
Excellent. Thanks very much. There is another question. I think it's mainly for Javier, because I'm curious about this. You showed the slide on the classic mechanism of PTCy, and the question is, what is the mechanism by which PTCy works if the destruction of alloreactive T cells is a less important mechanism?
So for sure, there is destruction of alloreactive T cells, but what we and others have published is that very likely the main effect is an upregulation of regulatory T cells. And regulatory T cells, as you know, are immunosuppressive. And that very likely is playing a major impact on the ability of GVHD prophylaxis by this drug. So now, whether that will come up to be the final mechanism, I don't know. But at this point in time, we believe that of the things that we know is maybe the main effect.
Okay.
Javier, is there any data on using TBI 12 gray in mismatch, one antigen mismatch unrelated donors with PTCy? I think in ALL.
Well, I need to really scratch my archives in terms of the exact dose of TBI, but we have published our first study with myeloablation and transplant cyclophosphamide that we published, I think, was in 2009 for matched transplants and one antigen mismatch. Allowed both BuCy as well as Cy-TBI. I cannot tell you right now by memory the exact doses of TBI that were used, but they were used with high doses of TBI. Yeah, so it's doable. However, in that particular study, the amount of patients who received TBI was a minority, even in cases of ALL. So it's not like we had hundreds of patients in that paper. But yeah, that was published in 2009, and Leo Losnick was the first author. So yeah, there are data.
Yeah, we do have experience in pediatrics, Damiano, with the 1200 TBI haplo with the kids.
There was a question in the Q&A.
Yeah.
I see Dr. Niederwieser with a hand raised. So.
Yeah, Javier, I'm talking now as an immunologist, and I have I understand your cartoon where you are speaking about alloreactions and allospecific T cells which are activated after transplant. If we are using this also for viral response, this is almost the same as alloreactivity. So you have CML memory cells, you have EBV memory cells, which are activated on day one when you are going to give probably the graft. So you will also kill them with cyclophosphamide. So that's the pure immunological understanding. The clinical is different.
Yeah, I think that we still are a little bit in the process of discovery on how this works. There is we are right now working on some biologic analysis about PTCy function after 1301. So we have samples on almost 400 change patients in which we're trying to establish cell populations and kinetics and so on. So I think that this is a story that is going to be evolving in the next few years. But yeah, you raise an important point, I guess.
Yeah, and for the clinical point, it's very important to have many patients to look if they are CMV positive or negative, which subgroups and so on. So it's much more difficult to show that.
Yeah.
But I would expect much more virus infection.
Dr.
Yeah,
George?
we saw, for sure, we saw in 1301 in the randomized study, we did see more viral infections in the Cytoxan group. But also, as I briefly mentioned, the increase was not in severe infections. So it was more infections, but severe infections were not different between Cy and TAC methotrexate.
Just like to add a point. So in the matched sibling donor transplants that we did for aplastic, not only did we see a much higher incidence of CMV reactivation, but these reactivations actually occurred very early post-transplant as compared to the cyclosporine methotrexate. We even had patients who just when they engrafted, they had already reactivated CMV. So that is very different from what happens when we're using cyclosporine methotrexate for GVHD prophylaxis, as what Clarice was actually showing in her talk.
There is another question, maybe it's linked to this. We have heard that there is no prospective randomized trials on dose reduction in PTCy, but I would ask Dr. George, what do you think if maybe there are advantages of reducing the dose to 30 or 40 milligrams per kilogram for 2 days? What can you tell us about?
So, I mean, I think we have to see the studies too. So there were some studies looking at reducing the dose in malignant disease, but in the haplo setting, coming down to 40 into 2, even 35 into 2, showing that it was as equally effective. I would biologically think that if we take it to the matched sibling donor setting, we may see viral reactivation being lower with lower doses, but we have to show that in a clinical study before we actually conclude on that.
Yeah.
I just have to say that I'm positive that in the next decade, we're going to see the studies looking into low dose of cyclophosphamide. But as of right now, I spent some time on Medline going through that. And all that we have is feasibility. Yeah, you can do it and patients don't drop dead. But is it more effective? We don't know. Is it more expensive or is it less expensive? We don't know. Does it work the same in GVHD? We have no clue. So I think that right now recommending these outside of a clinical trial will not be advisable.
Very clear. So I don't know, Damiano, do you have other questions?
I don't think so.
There is a question on the role of PTCy and ATG to reduce graft versus host disease and mortality in Hodgkin's patients who are on PD-1 inhibitors, if you want to talk about it. Yeah, thank you, Javier. I see you smiling.
Well, this is actually a very interesting subject in which we have spent many hours talking at Hopkins, because people who get drugs, immunotherapy before transplant for Hodgkin's, in our experience, develop a very interesting syndrome that is very similar to graft versus host disease. Perhaps it's graft versus host disease, but we don't think it is. Nonetheless, and they're actually very difficult to control and require very prolonged therapy. We have never used ATG on transplants for malignant conditions. We have lots of experience on PTCy and ATG for sickle cell, thalassemia, and aplastic anemia, but not for Hodgkin's disease. What we are actually trying to do right now is expand the time between immunotherapy and transplant, and perhaps consider extending the use of a calcineurin inhibitor after transplant, because we normally stop on day 60. So if we do a transplant for Hodgkin's on day 60, the patient will be off immunosuppression. And on patients who receive immunotherapy, we are advocating without any data to know if this is the way to go, but we're advocating for prolonging the immunosuppression at least for 6 months, which is something that we don't use for any other of our transplants unless the patient is receiving a mismatch unrelated.
Thank you. Thank you.
Yes,
Go
another
ahead.
question for Clarice. I don't know if we have some more time. It's about CMV monitoring post-transplant. The question is, when do you begin monitoring CMV? Just after engraftment or before? Number one. And number two, if you have some opinion about how to differentiate the blips from true reactivation, if there is something that we can do for that.
We start during conditioning, we start monitoring, because sometimes depending on the past of the history of the patient, they reactivation during conditioning, and then this is the time to treat them with ganciclovir, because we're not worried about toxicity at this point. And just because we have earlier reactivations, this is important to look at. And also concern to the blip question, there is some strategies that we can do in the laboratory, just like DNA treatment of the before extraction, DNA extraction, and then run the PCR. But this is time consuming and not practical in routine. So we still are getting used with if we see a sharp increase in the following days, we treat.
Very clear.
Adriana? Thank you, Clarice. I think there is one very quick question for Dr. George, as using PTCy to prevent graft versus host disease for patients with Fanconi anemia. If you have experience in the matched sibling donor setting for Fanconi.
We have used it in the haplo setting, where we actually use a lower dose of 25 milligram per kg into 2, but we have not yet gone into the matched sibling donor setting as it. So no.
Thank you very much.
We have a similar experience in Fanconi's dose reducing the cyclophosphamide. It's not that Fanconi patients grow on trees, so it's a very small group of patients, but again, it's doable. And in these patients, very likely they won't be able to tolerate the 50. So you pretty much, but it's also in combination with ATG. It's not as a backbone alone.
Thank you so much. I think we have 5 more questions to Clarice that we will not be able to answer, but we'll send to you by email, Clarice. I think you know most of the people who are asking questions. We would like to thank everyone. Dr. Rondelli apologized. He's chairing another meeting, but we'll have to close the session. Thank you so much. It will be very shortly in our website of WBMT, and I hope it may be very helpful to everyone. Thanks. Thank you very much.
Thank you.
Thank you. Bye.
Bye. Thanks.